Hi, Eliza. Hi, everybody. I'm doing this live as a video review. Now, this is something that I do in the full movement assessment. So there's a program that I do where people send in a bunch of videos. I review each video step by step. I do a review like this, much more elongated, but not as quick. And then I add a course to it so they know specifically what to work on. So I'm responding to your two videos that you're posted. I wish I could download them. I'm adding this over to my screen record, edited in together so you can see what I'm doing. I'm looking at again, yes, it's very easy to look at what's wrong and structural, but here we have structure that's causing deviations in movement, right? And so that's what I'm going to be looking at and where we are at. Now, please remember, you're only in day 3, okay? You're going to be learning a lot within the 7 days of working with movement lesson, working with segment 1, and then you'll be able to put more together. You're going to learn as you go, right? But right now, I want you to look at, again, the structure of your son's movements and what you're going to want to look at and to work on. So let's take a look at your videos. Thanks. Hi, Eliza. So here's a perfect example of what I do. So we asked for a video. So right now you're talking about practicing the water bowl, right? But you have dimorphic features, right? Which is perfectly fine. It's not round, almost pear-shaped. And very prominent occipital bone. But as you can see here, we have a very prominent frontal bones and all that. And again, makes the head very unstable is the wording you're giving. And by the way, the soft spot's still there. And the soft spot being still there is very similar as well, guys, in Down syndrome, right? You'll have a cranial deficit here, a push in here, and it pulls, and it takes longer for the either anterior, posterior fontanel to close, right? So now we're coming down into where I've asked to see a video, right? So now if I hit play and enlarge this, I almost wanted to download it, but this is where we're at, right? And where he's tossing around. So now as you can see, the frontal lobe is quite large. That's where most of it's being here, and you're looking at it, right? So now what are some things I'm looking at? My concern, first of all, is the pelvic region. I think that right hip is going coccyvalga. Now I'm only guessing, right? This is where I asked for hip x-rays. Any child that especially has dimorphic features in the head and vision is off like it is, I sincerely say that we need at least a baseline on the hips. Around the 1 year level, doesn't have to be really before, but again, we've got COVID going on and all sorts of things. By all means, the child's safety is number one. Just because I ask for anything, you know what I mean? If it means going into a hospital setting, which is something you're not careful, unsure with, that has nothing to do with me. But this is where I'm at. A lot of people are going to say more the hypertonic, but I think a lot of the hypertonic here, and I'm going to see if I can slow this down at all. No, I can't. Sometimes I can do it where it's reduced, and that's where I like going on my system. If I come back here, see again, right there, that's the move that I'm concerned with of the coccyvalga. It can come over to the left, but you can see where the trochanter's not balancing right as the child's rolling back and forth. And even there, the child's bending his leg and the left isn't. And I think it warrants hip x-rays for a baseline. Now, my other concern is now the vision. If you look at the way he's going, thrashing back and forth, right? When you have movements like that, nowhere in there do you have binocular vision. When you're tossing the head back and forth, that's different than looking and looking and looking, right? Can you see that? And so again, it could just be a stim, but this is where I have concerns with what's going on with the vision. This is going to be a hard one to see eyes because there you see the blur that I'm getting. Usually I can spot off if the eyes are a little asymmetrical and so forth, but right now the attention is on the head, which again can put the pressures on the movement, right? not necessarily cranial pressures. And now we're going to look at the other one. I almost had the eyes. So here you can see the eye alignment issue. See how the one eye is coming in and the other one's coming out forward. So again, suggesting patching, but let's just look at the video in its entirety. You really can see eye issues there. And he's coming back. So he's really trying to stable what's going on here. So if I come back, you can see again, eye alignment. Eye alignment, see it? Eye alignment. Now again, this is where the ophthalmologist comes into play, eye alignment. So you can see where it's not an intermittent, but structurally where it needs to be done. So part of the things, what you're doing there in the head technique, I'm just seeing if I can find one more. You can see again too. Now, see, this is where I'm trying to get, and this is where we have to work with the ophthalmologist. It could just be a cranial hit. One of the things I'm covering, sorry, when I have Facebook open and dings, one of the things that I'm covering in my CVI course about the frontal lobe hip being that much. So it could just be a frontal lobe tilt that's going on. And I can quickly explain that as well. So I'm just going to go in. And I think that's it that I have of just showing the eye alignment, which my concerns are. So again, structure of the eyes, where they're at. If this is just dimorphic features, it could be that the eye orbit is literally shifted. So we need to know the axis. It could be due to an astigmatism, and it could be due to just muscle weakness or muscle tightness. So those are the things that we have to look at with that. Now let me get into what we're talking about, lifting the head. Now, one of my real specialties is dimorphic features in the head region, whether it comes from vision, and yes, to me, an astigmatism is a dimorphic feature, whether it comes from cranial synatosis, abnormal skeletal growth in the head, sinus infections going on, that's just my specialty. It's like when I worked on this woman this weekend, and I'm like, you got thrown. Where is it? Did you get tossed from a horse? I knew it was, and her dad had taken off in the car and she flew out of the vehicle, and that's when her asthma and all her sinus issues happened. You know, people think like I'm a spoon bender, but I can feel these movements or lack of movements, however is your vocabulary. Now, guys, you're only into day 3, and we're getting into some heavy duty cranial movements. But again, understanding not what's wrong, but where the movements affect. So when you're looking at an infant's anatomy, and this is not a big anatomy course, but what I'm looking at here is the frontal lobes. What most people don't realize is the frontal lobe is actually 2 bones. The metopic suture comes in and closes up. Here you have your anterior fontanelle, or your front soft spot, your back soft spots. Here the superior. And the 2 frontal bones are there. Most reasons they think of is to get out of the vaginal canal more accessibly, right? Instead of having one large bone, the twist. But, right, if I think this way, coming to sitting, all those kind of developmental milestones come with that. And the frontal bones really have that kind of, I think, more of a ladybug than a seesaw. And then off of that, then you have the parietal bone, so you have the frontal bone. So as you can see, my brain thinks of the human body like a kinesic sculpture, right? And it's going in and doing all these things. That's how I can see a pelvis move. I'm not tilting to the left and to the right, you know what I mean? I feel the pubic bone, I see the tail, the coccyx, you know, all that happens with me. So now what you're also looking at here is the frontal sinuses. Now the sinuses, the frontal, the green is the ethmoids, the sphenoid is the blue all the way to the back, and the maxillaries. But you also have mastoid cell sinuses, which I only have one on, by the way, but I'll show you why in a second. But they actually go into the mastoid bones, and the frontal sinuses go, and so you can see where the sphenoid is almost to the middle of the head, right? So if I drilled a hole right through probably my zygomatic arch, I would come to my sphenoid sinus, right? And this is where too you get balance and counterbalance. So don't tell me it's all in your ear canal, right? And all of that is here. So when someone has a large frontal lobe and there's an issues with the way these sutures are going, you're getting more the windshield wipers going on with the head movements, right? Versus that twisty to twist. So that's where I would say with that 2-year-old, hi, how are you? Oh my goodness, right? Another way of looking at that, now here's an adult skull, which I've taken apart and it's about to fall apart again. But if I take off the frontal lobe, now the difference between an adult frontal lobe and a child's frontal lobe is huge, right? So you can see the difference of a developed frontal lobe on an adult versus a child. But I also want to stress, look at how deep it goes into the eyes, right? This is where you have cranial synatosis messing with vision, right? So 2 reasons for that. First of all, again, you'll see a little bit of the sutures left on the inside, but you really, for the most part, don't feel that ridge anymore, like on you and I, right? We think it's just our forehead or one bone, the frontal lobe, right? But also what happens, and if you look at here, the frontal sinuses go into the ethmoid sinuses. So the frontal sinuses are here, and there's a little lip right here where the ethmoid sinuses goes behind the eyes. So if the frontal lobe is too large, going on to that, off shape, dimorphic, again, it can go flat, it can go squished, it can go microcephaly where you have the indentations through the temple, we can go on and on. But that conversation of the bones with the sinuses then put stress, and that's what happened to my son, put stress behind and put on the vision. And that could be another reason why you're seeing eye alignment constantly like this with him, versus here, you know, where my eyes are even, versus again where it's up and the eyes coming in and straining out. Literally could be the pressure of the enlarged frontal lobe bringing out the, so again, when you're, look at my sinuses and my forehead, and if that got brought out, right? Can you imagine the tensions of the ethmoid sinuses are playing in with your vision? And that was my gram, right? And I learned to feel that. I learned to feel that. And again, I can look at it this way. This is why I have one mastoid cell sinus here, the purple one. So when I'm sitting here doing water bowl technique, right? What am I looking for? Well, obviously, let's say if this sinus was really enlarged and this wasn't, I should feel the weight differential. And then when I feel the weight, it will start doing this because it's a mass and it'll go to gravity. See the difference in crossing midline through the nasal canal versus this. So you're not technically doing the water bowl technique. The water bowl technique is there to teach you touch, the slow, working your hands and the movement around the system. As you get into this is when the neat stuff happens. You need more in these kind of conversations. This is more my cranial series where I really go into, because all your developmental movement milestones happens before this all fuses, right? All these little blue lines in there are the infant sutures, and they start fusing between 9 to 18 months. If you notice, all your developmental milestones are completed by around the 18-month level, right? So a child is meant to come to sitting while the temporal bone is still free and the mastoid can wrap around, and same with the frontal lobes, right? There's a different type of movement. And that's what I work with. This is what I've been feeling for years, and this is, again, a real treat for my hands. So this is something I want you to think about. Are you going to know how to work around it? It's day 3. We're going to go through it, but understanding your child, your movement, and then if you have all that going on, and then maybe a hip that's not acting the way it should, you know what I mean? That's where you get the complications. But then we're going to have to work on those rib cages and those sinus features so the movements start to come into place differently for the child. Thanks.